I'm Brad Power, and I think all of you know, the host and moderator of the Prostate Cancer Lab. And today we're going to be talking about discussion of the presentation that Bob Gatenby made a week ago on adaptive therapy using evolutionary and game theory to strategize about how to manage treatments. And for those of you who weren't there or didn't see the notes of the meeting, there are basically four pillars in that: drug combinations, low dose, sequencing, and mathematical models. And we were just talking about mathematical models. And just to get it on the record, Said, if you wouldn't just mind repeating what you just said about the complexity and sophistication of these mathematical models.
Yeah, thank you, Brad. We were talking about the old fashion of modeling, and which is be using mathematical equation to measure the change of the concentration of drugs in our system, in our blood, and then based on that that model, we can decide, okay, we reach to the 50% of the concentration, and then we can add, increase the dosage. This is what kinetic models, something which we can talk about. But this type of model are very limited because now we have huge amount of data, omics data. We should be able to use those data and find the interaction between proteins and genes. And then instead of the simple mechanical model, mathematical model, we can use machine learning, data science, predictive modeling to include many more factors in our equations.
Okay, so I'm a simple person, and I've read The Signal and the Noise, if you have, where they talk about weather forecasting and how the models get more sophisticated and the data gets more sophisticated. And what you're saying is the complex models, the standard of modeling today is to have many more variables in the model. Is that instead of just a handful?
Yeah, variety of model. It means it's not just a simple concentration of a drug. It's about the interaction between different components of the cell, like the mRNA, DNA, protein.
Okay, I've got it. And that's been a big theme that Brian's been interested in, of sort of integrating all the different kinds of information you could be bringing together, different kinds of omics, as well as medical history.
Right.
Okay. This is going to be just kind of an open discussion, but I want to cue a few things that came out of our last discussion. And I noticed Emma Shtivelman is on. Emma, if you wouldn't mind, you would put something in the chat about, I forget what it was, but it was something about a combination of factors or bipolar or something like that. Can you repeat your question that you wanted to ask Bob Gatenby? Emma, you're on mute. I don't know if you're speaking.
I'm sorry.
Yeah.
I have a cold. I don't hear well and I don't speak well.
Oh.
But the reason I asked about bipolar androgen treatment, it's because it's sort of taking the evolutionary approach that Gatenby proposes to an extreme. Not only you do short-time treatment, in this case with androgen deprivation, you then flood the patient and the tumor cells with testosterone, hoping that this will prevent the development of resistance, and the cells that were kind of responding to androgen deprivation will now flourish, and the resistant clones will be pushed out of the picture. So that's the idea. And I think Dr. Antonarakis is the big proponent of this approach, and he reported some successes, in particularly, I believe, in patients who have mutations in the DNA damage repair pathway. they respond well. I mean, it's literally case reports. It's not big studies. And also after bed deprivation, he reported that patients, again, several cases, they respond well to immune checkpoint drugs.
Okay.
Wow.
Yeah, he published a few case reports on the topic because his bed is fairly old. I think the first report was maybe 9 years ago or so.
Okay. And how do you
Yeah.
spell that? The doctor's name?
Antonarakis. I think he's
Antonarakis,
in
okay.
Hopkins, yeah.
Thank you.
I can share the references. I can find them easily.
Good. So bouncing around a little bit, I apologize, but I saw Pete Kane is on, and Pete's someone else I wanted to ask the question about mathematical models. I noticed, Pete, you were in a car, so I don't know if you can respond, but you're usually on a bicycle. So, Pete, is there anything in mathematical models? Do you have any resources or people you've run into in your career that might be able to help us with simulation models or of the sort we were talking about?
Possibly, I'll give it some thought for sure and see if I can make some introductions. Certainly, there's been a wide cast of characters that we've encountered.
Thank you. I also see Allie's on. I don't know if Allie is, if you're able to talk.
A little bit. Hi. Yes, trying to multitask a little bit, but yes, you have my attention.
Okay, good. So Allie, we were having a conversation in sort of on email.
Yeah.
Of course, we've had several conversations with you that you and CureMatch are a big proponent of combinations, so no problem with that leg of the pillar of the Gatenby Foundation. But you questioned or challenged the notion of doing them in sequence rather than as a cocktail combination all at once, and I think that's a very valid challenge or question. I think I can represent Dr. Gatenby's perspective a little bit here, in that what he's saying is that if you knock the population down successively, in theory, that's a way to get an extinction event. But if you hit the population, the heterogeneous population, when there's a large population, you're going to get some resistant strains that are not going to not respond, even if you hit it with a combination. You will get a better response. So, progression-free survival and some of the metrics will look good, but you won't actually kill it off. There will be some resistant strains that are lurking there in the background, and they will eventually come back, I think would be his argument. So unless, when he talked about Brian's case, he said, Brian, you have a low tumor burden, there's a low population, you can go for an extinction knockout blow if you take 3 drugs in succession. So he would, I think what Dr. Gatenby would say was, look at the CureMatch results, look at the, one of the drug combinations, but do them in succession, not as a cocktail. And we'll have to, I may be misrepresenting him, but I think that's the argument. Allie, you were just saying there isn't any evidence to support that, I think. Anyway, so just to open that up.
I didn't state that. I was asking because at a quick glance, we couldn't find any, but we may not have been thorough enough. So I was asking if there's any clinical evidence to validate this theory.
Yeah, sorry. Actually, I read a paper, I should find it, which not only they said the sequence is important, the order also important. They were using doxorubicin and another CTL for that type of drug immunotherapy. And they showed if you change the order, the effect is going to change. This is a big question, honestly. This is that's the, we don't know. I believe it is in many cases, maybe I have some idea about how you can make a cancer cell uncomfortable instead of killing a cancer cell, just make them uncomfortable. But this is, to me, based on my research I've done in the papers and everything, it is a very new field to me. This is many questions and a few answers.
Yeah.
There's
I know.
a specific example we've talked about, because Rick schooled me on the notion of radiation turning a cold tumor hot and then being responsive to immunotherapy. So that would be a sequencing of radiation followed by immunotherapy, just as one sequencing point that you're making, Saeed. Anybody want to comment on that idea?
That's our hope. That's my hope. I believe that's Brian's hope. At least we looked at assessment of our immune deconvolution as assessed by Tempest, and we have very cold tumors. Although I'm looking at our data now, our RNA-seq data in a little more thoroughly and kind of getting into the weeds, but it appears that our tumors are rather cold. We have some evidence of, T cells, cytotoxic T cells in perforin and granzyme A that a little bit contradict that there's no CD8 T cells, but it looks like there's pretty much no CD8 T cells. So immune modulation without getting TILs into the tumor microenvironment is probably not going to work without a prerequisite, which is current thinking is radiation. So it might be Pluvicto as a come in and basically carpet bomb anything that has PSMA on it, and that would awaken or heat up the cold tumor. And that would be perhaps the first step in what I'm thinking would be a great sequence. And then the second step would be immune modulators. Now, I'm very curious about what CureMatch and Ali bring to the table. When I first heard or saw the Tempest report with the super high BRAF expression, I took it with a grain of salt because, okay, I didn't get that on my report. I didn't get any section of overexpression. So I'm thinking, well, he gets one, I don't. Okay. Well, what kind
That's how you reacted, indeed. And I get you. I feel you.
So I'm
Yes.
going to take BRAF with a grain of salt. Well, I am looking at the transcripts per million data that's coming out of Tempest, and it was really apparent that BRAF is off the charts for Brian. Either they made a mistake, or that's a very reportable. That should have been reported for Brian, and it was. So then that brings me into the whole concept of BRAF. Okay, so you have BRAF overexpression. Nobody is really hitting BRAF for prostate cancer. Why would this make sense? And then BRAF is a signaling molecule or protein inside a cell cascade. So it doesn't mean that you have activated BRAF. It doesn't mean you have phosphorylated BRAF. It just means you have a ton of BRAF. So I make the analogy like it's a soccer game, and maybe at the cell surface is a EGFR receptor that is going to start a soccer ball from the goalie to the midfield, or to the defense, to the midfield, to the strikers, down into the nucleus. And so having a bunch of BRAF means, like, I have like 1,000 midfielders, but it doesn't mean they have the ball. It doesn't mean that they're being phosphorylated and actively signaling. But when I saw how high that BRAF was, it wasn't just a little high. Oh, it's Brian's is like 10 times higher than any, it's off the chart. So
like number one, I think, out of what, 500 patients?
Yeah, out of the Cancer Genome Atlas, prostate cancer, PRAD, prostate adenocarcinoma, there's 512 patients, and Brian is by far the highest of those 512, just really high. So you start thinking, well, maybe there must be some reason there's like 1,000 soccer midfielders there. That doesn't happen by chance. If it was a little bit. So then that made me very curious as to Ali and CureMatch bringing in BRAF inhibitors as potential therapies that I would have never thought of. And I think the medical community would have never thought of. And so I thought for Brian's case, okay, there could be a BRAF, therapy in the sequence, if we kind of can adhere to Bob Gatenby's. Now I'm blabbing too much and I want to hear what Ali, because I know Ali has got a healthy skepticism about the sequencing concept. So I'll turn it over to you, but I just thought I'd mention that I'm kind of like, whoa, maybe BRAF is a good idea.
Thank you. So, no, I totally get what you're saying, and thank you for sharing, because what you've just shared gave me additional insights, not just in how you're thinking about all of this information, but also some updates that you've been really digging into the expression data and even other data sets. And it's good to know that Brian's BRAF was that significantly overexpressed, even when compared to cancer population, where, like you said, there could be a lot of receptor tyrosine kinases, if not one, but the other, that could turn on expression of BRAF. In cancer, it happens quite frequently. Nevertheless, it was still overexpressed, even compared to the cancer cohort. If you were compared to the normal tissue, it probably would be even more significantly overexpressed. So that's good to know, and good to know that you're going through your data. I'm still, offering to kind of do the final pass with you to figure out which ones we should consider more seriously, to then try to run your CureMatch report again with that data in mind.
Thanks.
But I think what Ali believes is not so much that, okay, BRAF is the thing for prostate cancer. What I believe, what our company believes, what Dr. Kurzrock believes, and a lot of our, advisors and clients who are physicians using it believe, is that molecular matching is what we believe. So if you're having a molecular profile, it's one overall mechanistic biological picture of what's driving the cancer, then you want to be able to interfere with that biological profile as a whole, as comprehensively as possible. And if molecular matching is only possible for, let's say, BRAF, and that is the only marker there, and we know it's an oncogene and we know how to target it, there are drugs available, we're not inventing anything new, then this would be a potential match, again, alongside maybe with other matches. It's a set of options that we provide in a CureMatch report, but it's the degree of matching that has shown clinical correlation in actual prospective clinical trials. So the reason I have skepticism is just that the science says otherwise, because if you do sequentially, then it means that you're picking of multiple targets. Unless there's only one target, then we're not even talking about other targeted therapy options. So unless there's there's only one target, you're picking from multiple targets, just one chosen one to go after at a time, which means you're doing a partial match as far as the whole molecular profile goes, which means that in our universe, it's like you can think of it as a score. We provide a score at CureMatch. There's also studies that show, in categorical sort of matched, poorly matched, unmatched, very well matched kind of judgment. The studies show that when it's partial match, such as, just picking one out of the lineup of possible targeting mechanisms, correlates with poor outcomes. If that partial match is like you're only hitting one out of the 8 drivers, let's say if it's a lot of markers in the tumor, then it would be a corresponding, lower score. And what we see is, unfortunately, there are hundreds of patient examples, I wish it wasn't so many, of real cases from clinical trials with outcomes that show that when you just pick one, they may not live to try the next one. And that's what's really critical to understand here. So it's not just like an opinion and skepticism that's not based on anything. It's actually real solid clinical data published in top tier journals like Nature, and says that if you do a partial match, sometimes within 2 months or so, these poor patients had to check into hospice, and that's what's unfortunate. So the sequential approach assumes that you can afford to have just one, and then still have things turn out quite okay or not too bad, and there is no risk to giving a partial or a poor matching therapy. But I think that the data shows there is a lot of risk, and that's what worries me. So again, maybe it's still an opinion, but it's based on some facts, and it's an opinion of a very concerned person trying to help. There's more giants behind me that actually have that same opinion and also have seen it in their clinical practice. So I hope that puts some perspective to this.
So Ali, I've got a question. Thank you. That's super helpful. I wonder though, if those clinical trials, if it's not an exact match to Bob's proposed process, because those patients probably did not progress to another drug until they completely failed the first drug in the treatment sequence. And I think what he's looking at is, you're not completely failing, the first drug. You're waiting until you're progressing like halfway down, whatever his mathematical model would be. You're progressing, you're improving, but you haven't hit like nadir with that first drug. And then what you're doing is you're bringing in the second drug, and then you're attacking that way. And then you maybe bring in like a third drug. So, I don't know if that's what Bob's approach would be, but that's how I interpret it. I don't know if Rick or Brad, if you
Yeah,
concur
so
with that or not, but I think that's different than what you're talking about.
I just wanted, before you guys comment, just wanted to say, I think there's 2 points I want to come back to, the types of therapy and also the number of lines of therapy. But go ahead, Rick. I don't know if you wanted to add before I make those 2 points.
No, I'm good here for now. Thanks.
So for the types of therapy, I think I heard Dr. Rubinstein, please share that study with me. And I'm sorry if I should have read up on it from some notes, but I did not get a chance to. But if we're talking about first line of therapy, and we're not talking about targeted therapies, we're just saying like very broad action therapies, like we're talking chemotherapy,
Ali,
radiation.
Can I interrupt?
Mhm.
So he's talking about advanced cancer, clearly.
Okay.
So people that are past
Okay.
the standard of care, and he's talking about primarily targeted therapies, not chemo.
Okay, great, thank you. The second point is that there was a specific publication with our approach applied to treatment naive patients with advanced cancers and complex profiles, but they did not have any prior treatments. And that was published in Genome Medicine last October. I just shared, actually, it's one of the publications I shared with you this morning, Brad and Rick and Brian, so feel free to distribute. That shows the same exact pattern very strongly. It's almost a linear correlation that if you only address partially the molecular profile of the tumor, or the overall cancer and patient profile, then people do much worse. The PFS and OS are more poor. And if you have relatively better matches, it's almost like a linear, like the better the matches, the more you match of the profile, the better they do. It's not just like a black and white match, no match. It's really like, if you do a partial match, there's worse outcome. If you do kind of a semi-decent match, it's better. If you do a perfect match, it's a lot better. That's where the more remarkable, unexpectedly great results seem to come from. So again, I'm basing it on something that was evaluated in the prospective trial. And that's why I was asking if the sequential theory has clinical trial results, because I think to be compared on the same level, we should be probably comparing apples to apples.
Yeah, I don't think that data exists. I think that this would be like a novel approach. I'm going to bring in the voice of Saul Priceman, who happened to attend Bob's presentation last week. Saul runs the Priceman Lab at the City of Hope, and he suggested a potential approach where I would use, say, Pluvicto to target PSMA, and then use some of the other data that I have about overexpression of certain genes to then sequence in other targeted therapies. And I know that there's a clinical trial that actually does this combination with Pluvicto and Pembro. Now, I've been on Pembro, and I don't think that is going to work for me, but potentially a combination of, Pluvicto plus trametinib, which is targeting my graph expression, and some of these other things. What do you think about that approach?
Let me remember if you had the any kind of markers. I think you do. Obviously, it would make a lot of sense. I just want to review again, but I think it was multiple markers that could have had some drug targeting strategies. So the more of them you can combine, the better.
So I'm looking at them here.
AR, FANCA, and BRAF showed up pretty significantly.
Okay.
Your reports.
Right. If you go into the immune modulators, then B7H3 is super high, but Brian's androgen receptor is also wonderfully high and targetable. So that would just pop off the top of the list, even if it was cold.
Yes, and we did include that for our report as well.
You did. You suggested, for example, like apalutamide to target that, which would make sense.
Yeah, that's basically analogous, totally. And then if you combine it with trametinib, it would be very analogous to some of our sort of matched options.
So Ali,
there
let
was
me just
something
kind of
else, though, no, in your
let
some
me just
chemotherapy or something.
Let me push this just a little bit more. So, as far as I know, the only trial that Bob has done is the one that he presented last week, and that was using abiraterone. It was only 19 patients. I thought that the outcomes were very compelling. But what we're talking about now is not a monotherapy. We're talking about, essentially leveraging, cure matches, combinatorial drug approach, where we're looking at, multiple targets. How can we build a proposal that would leverage sort of cure matches approach for targeted drugs? I think I would probably throw Pluvicto in there as well. And I know that was not part of your solution. And the reason I would throw Pluvicto in there is because we do have this issue that I have a cold tumor, and potentially that would make it hot, partially hot. But how can we get some support to combine your approach with Bob's approach? Because intuitively, both of your approaches make sense and they seem very symbiotic.
Here's how: you try one drug and then you have them add another one in a week and another one in another week. Therefore, it's sequential. Problem solved.
I like the math. Every 7 days.
we do our own mathematical modeling on the fly here.
Yeah. So maybe. Okay. All right. I don't. Has Roselle ever, encountered this, or has she ever thought about, the sequencing approach, rather than the all-in-one?
Yes, my skepticism is it's a, how do you say it? Like, when they have those Star Trek movies with Borg when it's a collective. I speak for the collective.
Okay.
That includes Razel. Yes.
Okay. All right. All right.
I'm just the loudspeaker at the moment, but yes,
Yeah.
there's it's more than just Ali Perlina's skepticism, and we
I did
do
think
not. It basically doesn't agree. It's not that symbiotic to what we see as sort of
Bob.
the approach that is being having more of an uptick and reception and adoption in the field. It's just a wave that's coming up. It hasn't been, it's not easy. Medical system doesn't make it easy to just get like 2 or 3 drugs right away for any patient, and it takes some hoops to jump through, and we make these cases easier so the drug acquisition specialist can make the molecular sort of justification case for molecular indication of drugs or combinations of drugs, but it is doable. So and with that, we just our reality just seems so different from the sequential approach.
so. I wanted to. I remember that one of the things that Bob pointed to was pediatric leukemia, where the standard of care is 12 sequential therapies over a 1-year period, and it's curative. So that was one evidence point that he cited. I want to get into another aspect of this, but before we do, Emma, if you're still there, I know your video's off, but I'd be interested in your opinion on this general question about, since you've seen so many patients over the years, about this question of combinations and sequencing.
I'm in absolute agreement with Ellie about the need to use, not the need, the advantage of using combination treatments right away. But most of the time it's not possible. I mean, sometimes it's like pulling teeth. Once in a while, I would see a patient that has 2 targetable mutations, and I will search for trials, and I will find a trial that offers miraculously 2 drugs. Like I worked with a patient who had an ARID1 mutation, which responds in that type of cancer very well to ATR inhibitor. And there was also HER2 amplification present. And there is one trial that offers both drugs, which was ideal. I was so excited. She couldn't get into this trial, no matter what she tried. So she is receiving one of the drugs in a trial. She's doing well so far, but it is very frustrating. So none of her oncologists will prescribe both drugs. They're both approved. I mean, no, ATR inhibitor is not approved, but it's very unfortunate. It's my opinion. So that's why, QMH approach is correct, but it only, you depend on the oncologist to be able to prescribe, and Ellie talked about it, and that doesn't happen often.
So I wanted to segue to that. That was one of the key questions Brian raised a couple of times, which was, if this, let's just suppose let's accept our enthusiasm for the approach, and yet we don't see it. And so you say, like, whether it's combinations or whether it's sequencing, low dose, any of these things, they all seem to make sense from an evolutionary and game theory perspective, as a theoretical perspective, but getting them into actual use seems to be very much resistant. It's like resistance. There's sensitive cells and there's resistance. There's sensitive doctors and there are resistant doctors, but most of the doctors are resistant, or the system is resistant. So what is the element of that? So Emma, when you look for a clinical trial with 2 drugs and you can't find one, what's going on? Why is that so, even though it looks like it would be what's best for the patient?
Well, there are not that many trials that would offer 2 drugs based on presence of 2 mutations. You all know about the old MAGE trial, and there are others, the PUR, and they offer 1 drug. And whatever, 7 years ago, it was or 8, it was a huge progress because suddenly there was a realization that, oh yeah, there is a targetable mutation, let's hit it with one drug. Yeah, you give patient some respite from progression and sometimes pretty good response that lasts with the best drugs, with the best targeted drug responses. If a patient is so lucky, like very general, is maybe 2 years, usually much less, usually it's month. Can you devise trials, considering that, as we mentioned, the oncologists are reluctant to prescribe the 2 drugs? Can we devise trials that will offer drugs, including investigational drugs, combinations based on presence of more than one mutation? What do you do with the patients who don't have more than one targetable mutation? So it's not trivial, and the trial system is so slow and so inadequate that it's mind-boggling. But there should be trials that offer a couple of drugs, including investigational drugs. It's the obstacles are almost unsurmountable because, as you know, even if you offer 2 approved drugs, they're considered a new drug if you offer them together.
I want to mention another hurdle, and that is I am on a clinical trial of a 3-drug combination. And it's PD-1, adenosine inhibitor, and docetaxel, which is a chemo.
Mm-hmm.
And I am good pals with Arcus. I used to report up to the CEO at Amgen. And so I kind of chose that clinical trial because my doctors all said, you should get on a clinical trial with a docetaxel backbone. I go, great. So I got on it, and I'm traveling to UCLA as part of this. Oh, but it's randomized, and it's not double blind. So I got randomized to the docetaxel arm only, just because of lucky me. It's like, so that's just another hurdle. Even if you do meet all the eligibility requirement, you find, a combination that makes a lot of sense.
Mm-hmm.
You're still not, you can still kind of just like not make get the lucky 50-50 shot. Just thought of another, hurdle as a patient.
Tony, I'd like to call on Tony Crispino. Tony spent a lot of time as a patient advocate working with clinical trials and enhancements. Tony, do you have any comments on this conversation?
Well, the development of clinical trials have control arms for a reason. We have to have those control arms, and that, unfortunately, we can't select being on an active arm of a clinical trial because that's simply just not the way it's done. We have to have the control arm to go ahead and make sure that we're following the same criteria for both A, the control arm, and B, the experimental arm. And it's very important that this randomization takes place to bring the integrity of the trial to where it can be practice changing. It's very difficult to tell a patient who got onto a clinical trial, but they ended up in a control arm, that they ended up in a good spot, but technically you did, because there's another side of this trial. It can fail and the drug isn't effective, in which case you're receiving morbidities and side effects from a drug with which isn't going to help you. So it's important just to know that the purpose of a clinical trial is not to provide treatment. The purpose of a clinical trial is to provide an answer to a question. And in the particular question, as it's put on out, can we combine this drug with the standard of care based on docetaxel? That's the question. Then you have to, what are you comparing that question to? I don't know if you guys are familiar with PICO or PICOT or PICOTS. This is how scientific questions are asked, and it's how we develop questions every time we do a clinical trial. Those questions are the key for you to look at. Is this trial going to provide this drug, and that's how I get those drugs? That's not, you have to look at the question that's being asked for that clinical trial to understand, where you're going to fall into this. So, Rick, as bad as it is that you think that you got onto the control arm, you're actually playing just as important a role as the active arm. And I know that that's not something to cheer about, but it's very important that we have you there.
So Tony, you responded to Rick's specific frustration.
Yeah, I did.
But there was a more general question that prefaced that, which is we have what looks like combinations. So let's just take Emma's example. I have a patient, has 2 drugs. I'd like to be able to have that patient get access to those 2 drugs, but there's no oncologist that will prescribe it. There's no clinical trial because those 2 drugs have never been combined before. Any thoughts about why the system, what systemically, typically when there's something that doesn't seem like it's common sense from the patient's point of view, there's another good on the other side that's going on. Do you have any comments on what's going on there?
Well, I think I kind of touched on it, but yeah, again, what does it take to go ahead and create these trials and get them coming on board? Whether it's to develop a hypothesis that goes back in that there's a reason to combine these 2 drugs and getting this done. The reason why clinicians are negative about going forward and just doing it and just choosing to do it is, there's kind of a question of some ethics that are involved into just, well, here's a drug, let's try this one. Here's a drug, let's try this one. Because there's, it hasn't been explored what the negative effects are going to be. So a clinician is going out, and the clinicians on here can probably agree with this. They're going out on a limb and prescribing something that's outside of protocols or a guideline that's out there available today that is scientifically proven in the guideline on when and how to use it. So anytime you step outside of a guideline and you start doing this, you're stepping into a higher risk situation for both the physician and the patient. So the safest thing to do is to keep them within the guidelines of what's proven. And in the guidelines, when we write them, we talk about the insertion of trials and so forth like that, strictly because there's no real general benefit to picking and choosing which patients you're going to be doing this if we're not trying to do it in research. And typically our statements in guideline will say, if you're going to do something different here, do it within a clinical trial. So that is in the guidelines for physicians to follow. And I think that any physician level can add on to this, but this has been a tried and true methodology that we follow. Now, does this mean that every time we get into a circumstance of a new experimental drug, we're near end of life for a patient, that we might give that a shot? That's entirely up to the stakeholders here. And that would be the clinician and the patient themselves to try something like that. But in almost every instance, it's going to be to try to develop the hypothesis, put the question to it, put it into a trial, and give equal arms, equipoise within the trial to try to arrive at something that can change practice. Again, that's practice changing. What you're asking for is, can we change the direction of an individual anecdotally? That's very difficult.
Yeah, I think what we're facing here is that if you take the combinatorials of multiple drugs at multiple doses and in sequencing, and we've already uncovered here the complications or art that would have to go through to sequence the drugs, that you would be coming up with such a personalized approach that it would be difficult to create the statistical evidence that would come through a normal randomized clinical trial. And I think Bob Gatenby made that point. So to the extent that we are proposing a strategy, a treatment strategy that is antithetical to the design of the number you would need in a sample to make it valid and achieve evidence over a multi-year approach to get that evidence, and I guess the money that's required to fund one of these clinical trials, it's not going to happen in that patient's lifetime, or our lifetimes. It's
Right.
It's like a clash of strategies. I'm sorry. Go ahead.
No, it's just, I mean, logistically, it's very difficult to run a big trial like that. Say trial that manages, like MAGE trial is run by NCI, which obviously has some power. And they, you know, they offer single drugs. So they have agreements with the manufacturers to offer these drugs in a trial that, you know, may or may not produce some meaningful results. But if you're talking about combinations, the trial will have even difficulties to accrue patients because they will offer, say, they will have a list of, say, 30 drugs, targeted drugs, and patients who have mutations in 2 of the targets for which there are drugs, which is not a very high probability, will have to be directed to this trial. So the problems are tremendous.
Mhm.
I
Yeah,
believe in
Yes.
To add on to
Ali, I'm
that,
sure this is a problem that you have come across. I mean, your whole business is based upon combinatorial approaches. You know, how is CureMatch thinking about increasing the penetration rate of its solutions with patients and with physicians?
Well, that's actually a great point and question, really. We're trying to kind of help or empower the system from different angles. One is, of course, physicians themselves. We help them make the case to get the drugs, and it does work. It's just more difficult. And I think for a lot of the obvious facts that have been stated, that, you know, it's challenging to get many drugs at the same time. Let's just say, at least for your case, for Rick's case, for these cases, just because something is challenging doesn't mean we're not going to try it, right? So it's not a reason to say for the current cases at hand we're going to just give up before trying. But in general, what we're doing from the company perspective is we're approaching this more from a medical institution level. Now we're talking to different centers, showing our evidence. So it's not just anecdotal, and we point to the evidence and see if there could be a bigger kind of partnership type of adoption through also the NGS companies, because in partnering with NGS companies, some of them put us on their test requisition form. So they take care of the actual, you know, journey from when physician orders NGS, where we're basically the next bus stop that makes sense in tandem. That if there's anything to CureMatch, then we will produce a report. So that just makes it a little bit more habitual and seamless for the patient and the doctor. And then finally, very importantly, we're in the process of getting our CPT code to help with reimbursement, which also helps in a way with credibility as well, makes it a little bit easier to adopt in any medical system. And we have a new type of solution that's kind of like a calculator, value calculator, where for any ranked number of options, where it can be not only CureMatch, but let's say you'll rank other options in there, on a scale from 0 to 100, that's all it would take. It will actually rank the value indicator, value index, which is a combination of the money it's going to cost for the score, like the matching score that, or the matching rank that is given to any given option. So if 2 are, let's say, extremely close, same score, or 1% point difference, and even with the same score, we provide alternative drugs, and I've shown that before. But if all things are almost equal or equal in terms of the molecular match, what would be the most realistic sort of affordable option to get? So the overall value is kind of like the financial value plus the clinical value, and getting the best balance is what the calculator would offer. And with that, we're going to be more and more approaching payers, and we already had some presentations and early evaluations from independent parties that say that this might actually be very promising. So I'll stop on that point. But before this meeting is over, I just wanted to share one more point about the evolutionary perspective, which does come from a study. It's just not published because it was a confidential study. But I wanted to quickly take just one more second to say that when there was a collaboration with participation of a medical center and also another company, and it was confidential, but for what it's worth, I'll share that there was longitudinal data like I've never seen before. We saw like 6, 7 samples for some of the patients. And we had no patient samples less than 4 longitudinal samples with treatments in between. And then it was like about half a year to a year apart when the samples were taken. And what we saw is that there are mutations that appeared in the beginning that disappeared for 2 next rounds, reappeared for the 2 final rounds. And then we see the treatment history, and with the treatment history, it's very clear, like, okay, they saw this one and a few others. They only picked the EGFR inhibitor and nothing else. EGFR markers or related EGFR markers went away, did not get detected, or maybe just barely passed the limit of QC for the clinical lab sequencing detection, and didn't get reported. Then it comes back. And that happened in a whole cohort. It was solid tumors with clinical data collected from a medical institution. And also at CureMatch, we a lot of times get Tempus reports that summarizes things just more conveniently. We don't get 6 longitudinal samples there, but it's quite frequent that we see 3. And when we see 3, we see that some mutations from the first round disappeared on a second round of testing, reappeared again. And sometimes their allele fraction really varies, like it barely passes. That leads me to believe, and not just me, that when there's some population of a tumor with a driver, even if that driver is targeted, I don't think there's any evidence to believe that you completely extinguish that cancer population. And in the meantime, while you're targeting that driver, other ones completely take over because you're ignoring the other drivers. And that is also shown in longitudinal data. So I think even though that is not a publication I can specifically point at, I just really wanted to share this because that's from real data sets.
I know we've only got like 5 more minutes. I want to try to see if we can get to maybe some action here, because I see some opportunities and I just don't want them to be obscured. So first off, do we all agree that a combinatorial approach makes sense? Going after one target is not the answer. Is there anybody that disagrees with that? Do we all agree? Raise your hand or stand up and dance, whatever you need to do. Okay.
I agree, but I have some
caveats.
hesitations, but I agree.
Okay, in general.
Yeah, I agree, and I can prove it.
Okay, perfect. All right, awesome. Okay, you're on the team. Okay, so, all right, so Ali, CureMatch is very tightly linked into UC San Diego. Roselle's there, and I'm sure others are.
She's not.
Oh,
she's gone a long time ago. She left UCSD. Yeah.
Oh, okay. Where I was going until that premise was just left the door. It's still the idea could still hold though, right? Which is how do we focus? And it doesn't even necessarily need to be me, the patient. How do we figure out how to work with an institution? Maybe it's MD Anderson, maybe it's UCSD, maybe it's whatever, right? Fill in the blank. Wherever CureMatch has really tight relationships, how do we work with you to create like a virtual tumor board where we can have your entire team or the appropriate people work with, I'll just say for now, like Raina McKay at UCSD, my doctor, Rick's doctor, to go through and have a conversation about what this approach is and how we can actually put it into action for me or for Rick or for whomever. I may not be the best candidate because if I look at my highest scores is like a 32% on the Pressy report, right? So,
but that doesn't matter.
Okay. I saw it before. It used to be 70%, so now it's declined. But how do we create like a success story, and how do we get focused around creating a success story for your solution?
I think, don't worry about it. We're creating our success story just fine. I worry more about creating success story for your and Rick's cases. And I think that's really why we're here. And if we
Yeah.
can help and it's successful, the rest will take care of itself. If it's really something that makes a difference, it will only be a matter of time until more and more people are convinced. And, it can happen sooner or later, more publicity now, less publicity now. I really don't want to put that as an objective. I mean, why? So
Okay.
for you guys, I think, okay, before we solve all the world's problems, I think for you guys, it's just getting the more of the precision oncology minded physicians, at least to the table discussing your next treatment strategies. And, it could be actually some of the physicians from UCSD, if they're available. If you look at the papers where Razel is the senior author, and I just shared them this morning, some of the co-authors or the lead PIs on the trial are actually practicing oncologists that are very much, precision oncology focused, as opposed to just, one type of cancer focused. Not that there's anything wrong with that. So, I mean, just suggesting that if you can, and I can speak to Dr. Kurzrock, but if you can get these types of clinical minds in the same room, their word will go much farther than mine or my team's, because it's more like peer-to-peer, oncologist to oncologist. And with that, of course, I'll be happy to participate if there's a tumor board like discussion. And I think that's where you'll see what they're willing or not willing to suggest, and what your doctor is willing to do or not willing to do.
I want to wrap us up, just monitoring the time, and Mike Yancey has his hand up, so I want to catch him before we wrap. Mike?
Basically, I was just raising my hand when Brian asked the question about agreeing with this. And so I was just basically saying I agree.
Oh, okay. Agreeing is good. Okay, that's all right. Brian, are you complete, or is there anything you wanted to summarize or say?
Yeah, no, I agree with Ali. I think I was being maybe a little bit magnanimous in terms of trying to support what they're doing. Yes, I think, obviously creating a solution for Rick and for me are paramount. And so maybe it's, maybe I just need to chat with Raina about how we convene some sort of virtual tumor board with you and whoever else we need to have as part of that group.
Well, there are several people from Cancer Commons here, Emma, and I guess it's Shan Fowler. And they offer some of these, kind of expanded access. And Jeff Waldron, I'm surprised he hasn't chimed in. He usually chimes in with expanded access, compassionate use, that's his thing. But there are such things as N of 1 clinical trials that if I think there is a bureaucratic, procedural, regulatory approach where if a doctor, like you're saying, if Raina McKay was willing to go to bat for something, she can essentially create a clinical trial for you. There's a bunch of bureaucracy that surrounds that, but it's doable. And so that maybe we need to pick that up on a subsequent conversation. And then you could be the success story role model that others could emulate.
Yeah.